Okay, let's get started. Good afternoon, everybody, and Happy New Year. I wish everyone a joyful and, most important, healthy New Year. You already heard from Ananth. Devika, I don't know if you want to say a few words before we start the first meeting for this new year.
Let me just add my welcome, really. Happy to see you all here and Happy New Year.
All right, so the purpose of this meet and greet is to all know each other and to ask any questions. And as Anna mentioned, is collect to strengthen our relationships, connect technologies with clinicians and the other way around. So without further ado, we don't have a lot of speakers for today. So if you want to raise any other issues, feel free to do so. But out of respect of the speakers, let's start with the first session. Anath, I think you are the moderator for the first session, correct?
Yes, absolutely. So our first speaker is Hvac from Rice University, and I see him on the call. So Dr. Barua, over to you.
Sure. Thank you so much, Anand. And it's great to be here. Happy New Year, everyone. Okay. All right. Yeah. So I'm a postdoctoral researcher at Rice University. I'm a part of the Scalable Health Labs led by Dr. Ashutosh Sabharwal. And the purpose of the lab is to develop software and hardware solutions that can help us understand health and aspects of disease. So it's something like building mobile phone apps all the way to building video cameras that look at specific wavelengths to understand blood flow. My specific research interest is more on the software or the computational side. So I use techniques like machine learning, data science, statistical analysis, as well as leverage a specific skill set in signal processing from my electrical engineering background to understand data better. So the first sort of research interest that I've put down here is data analytics for data coming from wearable sensors and medical devices. So it can be, and specifically what my interest is in data that is in the form of signals. So something that is varying with time or varying spatially. So for example, something that varies with time is like an ECG signal or continuous glucose monitoring data from a CGM device. It could also be spatial. So it can be something like an MRI scan or a CT scan, which are CT scan, which is an image, or a pathology image from cancer, or it could be spatiotemporal in nature, or videos essentially from endoscopes, for example. So my research is trying to use these computational techniques to gain insights about health and disease progression. Okay. So like I believe Anant just mentioned, for those of you who weren't there just a few minutes back, it's really important to identify meaningful problems and to try to really understand the specific problem that we want to handle. So sometimes I call myself as just a translator for translating what a clinician wants to solve into the statement of mathematics and computing. So what I like to build are clinically interpretable computational tools, and the tools themselves are clinically inspired. So if you want to detect, let's say, certain morphological features in an ECG, then the techniques we built are geared towards that, as opposed to a one-size-fits-all kind of computational tool. And the second thing is, it's all well and good to have sophisticated computational tools. How do we actually communicate the information to clinicians in a way that helps them guide decision making? But also for things like wearable sensors, we also want to communicate information to patients and try to help them understand their health better. So that's what are the sort of unique resources our lab aims to contribute. Next slide, Don. Right, so as some of you might have surmised, we try to understand patterns from signals and patterns that are clinically meaningful, especially in the age of telehealth and remote monitoring. We are very interested in problems that you might have in understanding video data or image data or just signal data. And also, we work with small and medium data as well. So techniques that I mentioned, like signal processing, sometimes give a lot of insights that techniques like deep learning, for example, are not suited to that size of data. Another motivation of myself as well as our lab is in working to help health disparities and trying to understand how digital health technologies can be used by underserved populations and underrepresented populations when it comes to research in these arenas. So those are the kind of assistance we would love, or collaborations we would love to have. So data sets that have this temporal or spatial nature, and you want to understand something from them. And also data sets that come from these underserved populations who so far have not been represented well in these kinds of research. I've just put down a couple of RFAs, but anything that requires clinically interpretable computational analyses and possibly working with patients who are underserved. So those kind of RFAs are of interest to us. Next slide, no? I believe I will probably be running out of time, so I'm just going to leave you with one sort of example of the kind of research I'm working on. And really, we see ourselves as the link between the data that we collect and how can we actually act upon the data, right? So I've put down this framework called the Measure, Model, Modify framework, which characterizes a lot of digital health technology, where you have a device or some ways of measuring data. And here what you can see is a continuous glucose monitor recording continuously the glucose levels of a person with diabetes. And what we want to do is understand something about dietary patterns, for example. So can we understand the relationship between diet and how your glycemic response is? And that's what biobehavioral understanding is all about, linking the biology, which is the glucose level, with behavior, which is what are you eating. And then hopefully this can help clinicians and behavioral scientists identify how can we really help patients with type 2 diabetes modify their behavior more efficiently, and something that sticks and actually helps in clinical outcomes. So yeah, with that, I'll stop and take questions.
Questions from anyone on the panel?
I would like to know a little bit more what is being done and what you're doing in terms of health disparities. That's actually an area that is of interest to me. And I do work with many racial and ethnic minorities. So if there is anything specific that you're looking into, it would be most interesting to me to hear about it.
Right. So this exact work that I'm talking about is being done in collaboration with Sansum Diabetes Research Institute, who work with food insecure Hispanic Latino neighborhoods in California, specifically Santa Barbara. So these are individuals who are food insecure. So there's no food security is not there in these populations. And so what this institute is doing is giving them free vegetable prescriptions. And we use continuous glucose monitoring technology to see if free vegetable prescriptions actually helps improve their, let's say, the HbA1c, which is a marker of their level of diabetes. And what we are seeing is indeed it does help. So we are developing new metrics to look at these glycemic profiles to understand the changes and to see that indeed there is an improvement. So to answer your question, what I've been doing is using temporal analysis techniques to see improvements in their or changes in their glycemic profiles before and after in these underserved, food insecure Hispanic Latino population out of California. Does that kind of answer your question?
Oh, yes, definitely. Thank you.
Thank you.
So Sutik, how does that actually work? Because HbA1c moves on a very slow time scale. It
Right.
probably moves on the order of 3 months or so.
Yes.
So how important is real-time monitoring for HbA1c?
Right. So this vegetable prescription sort of intervention lasted for 3 months. So we monitor glucose levels for 2 weeks before the intervention started and for 2 weeks after the end of the intervention. The official guidelines from the ADA say that we want to at least look for 2 weeks of data to understand, to derive metrics or measures of understanding. So over these 3 months, we did actually see the HbA1c falling. Interestingly enough, falling quite sharply for the diabetic participants. So some of these participants were more diabetic than the others, and some were pre-diabetic. But what we saw was that we could see drops in their HbA1c for the diabetic participants. What I sort of was able to show also was that while in HbA1c, some of these measures for the pre-diabetes, let's say, participants was not clear, but certain aspects from their glycemic profiles using these time series analysis techniques, we are seeing that there are like significant changes, which the current established sort of measures or metrics are not capturing. So it's still a lot of work to be done. But that's why we have this 3-month sort of period so that the HbA1c also, we can see changes if there are any. And then we have these novel sort of metrics that we are designing. We have 2 weeks of data to capture them. And the official guidelines say that 2 weeks is sort of where you want to start making conclusions from.
Okay, interesting, thanks.
Yeah.
Any other questions?
So do participants maintain a food log that is also part of your analysis?
So that is a subsequent study that we are doing. So this was a study that started just with no interruption. So the participant also does not, for example, know their own glucose level. So they wore blinded glucose monitor. So we tried to capture as much of a free living lifestyle as possible. But in a subsequent study, we want to capture food logs to actually verify or validate some of these diet behaviors that we want to analyze and capture.
Yeah, because in a food desert, even if you have a prescription for vegetables, you have to make the effort to go and get it and then cook it. Because there's a lot more involved. So maybe harder to establish a causal relationship. This is fascinating, though. I just want to say.
Yeah, you're absolutely right, Devika. I think that's also a subsequent study we have, is to distinguish what happens if we give recipes as well to the individuals and also help them do the grocery shopping versus not. But what we are seeing is that there are definite glycemic changes in their profiles, and so we are not saying it's causal, meaning that it's because of the vegetables, but something is happening that we are seeing for sure.
That's great.
Yeah.
Okay, so the next speaker up is Dr. Faustinella from Baylor. Fabrizia, over to you.
Thank you again for giving me the opportunity to at least introduce myself. I'm at Baylor. I'm currently in the Department of Family and Community Medicine, but I'm an internist. I trained at Baylor, moved to UT, and then I returned to Baylor in the Department of Family Practice, where there was a position I was interested in. My research interests so far, or at least the areas where I've been able to work, publish, and create content, are clinical skills and clinical reasoning, definitely clinical patient care, issues of access to healthcare, homelessness, and narrative medicine, as long as issues of racial biases, but everything that I worked on kind of became intertwined. So everything you see there, clinical medicine, access to care, homelessness, racial biases, it's kind of has led to really a focus on healthcare for racial and ethnic minorities and access to care. My resources, really my main resource is the access to patients. And the bulk of my work has been in clinical medicine. Next slide, please. So I do have a lot of expertise, of course, in clinical care, outpatient and inpatient, although currently I'm mainly in an outpatient setting. Medical education and remediation strategies, clinical reasoning, analytical skills, and critical thinking skills. What I'm actually looking for, and it's just so wonderful to have people in this cluster who are so knowledgeable and already know a lot about artificial intelligence, is actually to learn because I'm a clinician with really minimal experience, and not only in computer sciences, but also in working on AI projects. And so when a few months ago, the AI bootcamp was mentioned, I definitely became very interested in that as an opportunity to train and learn more about it. I don't have at this point a specific RFAs that I could mention, but basically any practical application in the field of primary care, internal medicine, and in the field of clinical decision making. Mainly in the outpatient field at this point, since is where I'm working mostly. But that's something that I'm definitely interested in. How could AI improve the care of our patients? And as I mentioned at the very beginning of the meeting, yes, I came to realize that the questions have to be indeed pretty specific, although I maybe not so specific, right? But thank you. I'm eager to learn from all of you. This is mostly interesting to me, and I appreciate being here very much.
Thanks, Fabrizia. Questions from anyone?
I can go first. Thank you very much to all the presenters. Fabrizia, you used a word that I'm not familiar. Can you explain and talk a little bit about narrative medicine?
Oh, very good, very good. Yes, actually, narrative medicine became really a new field of medicine, a legitimate field of medicine. If we have a little bit of time, let me tell you how that started.
We have time, so you can take the long way.
So the creator of this narrative medicine field, and it's so interesting that just not too long ago, I gave a presentation about it. Basically, it came to realize that not a lot of in the patient-physician relationship, something was missing. What's happening, or what it was noticed, is that the encounters were too rushed, and not a lot of attention was really given to the patient. So the idea was to do something which helped students initially, helped students to become better listeners, and to really be able to interpret, analyze, and act upon the stories of the patients. And so initially, it was thought that writing about patients' encounters could actually help the students to focus on taking a better history from the patient. So that's how the field of narrative medicine got started. Let's ask the students to listen to the patients carefully to become better listeners. And how are we going to do that? Several literary texts were introduced to the students that they could read, analyze, discuss, and then eventually apply those close reading skills to listening skills. The field became immediately, this approach became very interesting, not only for the students, but also for a number of physicians and faculty members. And so over time, this field of narrative medicine was created where there is an attention to close listening skills and prior to that, close reading skills. So applying those close reading skills to listening skills revealed to be very beneficial in terms of creating a better patient-physician encounter. Several years ago, we're talking about 20 years ago, this field was created and it evolved. It became also something that has been looked at as a tool to fight stress and burnout. So when a student or a physician sits down and reflects on the patient encounter and writes the patient's story and reflects on how that can even change the physician itself, then there is a process that leads to the ability to fight stress and burnout. So initially, narrative medicine was intended to improve the listening skills and the patient-physician relationship, but later became a tool of self-care as well, where it's been, I would say, kind of proven that it can really positively affect stress and burnout. So narrative medicine now is very prominent, not only at a national level, but also internationally. There are schools like Columbia University, which offers a Master's of Science in Narrative Medicine, and pretty much every medical school has a narrative course now, which is part of the curriculum. So at Baylor, we do have a mandatory narrative medicine course for third-year medical students. And other schools are doing the same in addition to providing training programs. So I don't know if I've been clear, but please feel free to ask questions and I'll be happy to answer.
Thank you very much.
It's actually very clear, and the terminology was new to me too. So thank you for the clarification. And the thought that immediately comes into my mind is this is an opportunity for natural language processing.
Yes, yes. In fact, when we look at the strategy used in narrative medicine, which is the first one is close reading. So paying attention to the who is speaking, what's the point of view, where are we, time, historical period. if we look at those close reading skills, a lot of that actually translates to the close listening skills, because there are really areas of the brain that process the written language the same way the spoken language is processed. Some of the areas overlap. And so really, that's very interesting, because the way our brain processes language, it's actually at the foundation of why the close listening skills, the close reading skills can actually translate into increased listening skills. So there is a lot of that going on. So definitely language, yes, and brain processing.
Yeah, this also seems highly related to a slightly different, but I think a similarly inspired idea. And this is Dr. Abraham Verghese, who wrote a brilliant essay about how to do a physical exam, which I read. I'm not a physician, I'm a computer scientist, but that really opened my eyes. And I think the point he was making, and I think the point you're also making, is that all the technology that has invaded medicine right now really creates such a distance between the patient becomes an abstract object rather than like another thinking, feeling person. And I think the narrative aspect that you're talking about, which Abraham Verghese translated into, like when you touch the patient, you're really making that physical connection. And here you're using language and close understanding of what the patient is saying. I mean, it's wonderful. If more doctors would practice this, I think it would be a revolution, no doubt.
Definitely. And that's why actually the field developed to create patients-physician encounter that not only would lead to better listening skills and therefore most likely to the ability to make the right diagnosis, yes. But also to, which seems strange in medicine because we go into that also because of the human aspect of it. But very often it's almost as if humanity is taken out of the patient-physician relationship. And so one of the goals of narrative medicine, it is to reintroduce that humanity and the ability to relate to the patient. So that's definitely, and as I said, it's almost a little bit counterintuitive because a lot of people go into medical fields because it affords them to have this human interaction. But ironically, sometimes that doesn't happen, which actually begs the question of why. And that what leads us into the other big field of stress and burnout, which is so prominent among healthcare professionals. And when people are very stressed out and burned out, truly there is an erosion, sometimes even of humanity and our ability to relate to other people. And that's why eventually narrative medicine became important. It was, again, the intention was not to be a tool of self-care or a tool to fight stress and burnout, but then in fact it became one because it allowed to reintroduce that dimension of humanity into the patient-physician relationship. So these fields are pretty much intertwined as well.
Great.
Thanks, Fabrizia. So in the interest of time, I'm going to hand it over to Yanni for the next set of talks.
Thank you, Anna, and thank you to Dawn for putting a technologist and a physician in the first session. we will see how the rest of the day will evolve. So the next speaker is my friend and colleague Shachuan Zhang, and
Hi.
he's always giving exciting presentations. So Shachuan, the virtual microphone is yours.
Okay, thank you. So I'm a faculty at the School of Biomedical Informatics at UT Health. Originally trained in computer science, and I've been working in biomedical informatics for 10 years now. So my research interest main is on like health privacy, synthetic data generation, differential privacy, supporting federated learning, building a large cohort from small silos without sacrificing information. I also work on a lot on the counterfactual analysis on drug repurposing and treatment recommendation. This kind of technology can also be used to explore and generate hypotheses. As compared to hypothesis testing, giving the raw data, I'll be able to pull like what the data says about the cause and then effect. So I've been recently working with stroke physicians and identify very interesting patterns on what needs to be trained first, what needs to be trained next. I've been working on temporal aware predict model for trend analysis and phenotyping. So I've been recently working closely with the ICU at UT Health to come up with predict model to predict which patient may likely to be sent to ventilator. What we found is traditional model, even though they can do very well at any given time point, they are not stable over the time spectrum while the patient is in hospital. The reason being they're trying to over-engineer the feature at any particular point, and patient can be sacrificed for the sake of just a cross-sectional performance. So we have a model which is more stable and more robust. In terms of unique resource, we have developed a very strong GPU center with more than 15 GPU machine, over 500,000 GPU core, including both the latest DGX2 and DGX3 in place. We have access to large clinical database, Optum and UT Physician, and some portion of the Memorial Hermann inpatient data. And I also lead an international consortium on COVID-19 research. Next slide, please. So I think I can contribute to the cluster by methodology in terms of machine learning and predictive model, also contribute to the educational component for future grant writing. I've been directing the UCSD there's a training grant, T15 summer training program for the last 7 years. So I hope like in the future, I can transfer my previous experience in future educational grant writing as well. And I'm mostly interested in collaborating on real world high impact clinical project with a potential to put predictive model into practice and seeing feedbacks from patients and outcomes. In terms of the expertise, I'm looking at people who are very interested in deep statistical modeling. So I'm thinking like a lot of detail, like advanced sophisticated statistical modeling has a lot of commonality with deep learning, but there's some way to integrate them to provide both interpretation and performance. I'm very interested in clinical trials, if there's any opportunity to participate. My research also involves a lot of chemistry and pharmaceutical informatics work and HCI for telemedicine. So I'm looking at some of the grants from NIH. Many of them are neurological, Alzheimer's disease, and then PCORI, stroke, and like kind of clinical trial studies. Next slide. So this is one of junior faculty working with me, and she came up with a method. So we're looking at drug repurposing, and among the top drugs, many of them are used by Trump actually in the combination cocktail. So this was before he announced the list, and then we compared 3 out of the 6 was overlapping. And beyond that, we can also look at who should be given what and which combination, depending on their comorbidity. For example, if diabetes, if they have hypertension, if they have stroke, the preference will be different. The way how we look at it is we combine the phenotype, genotype relationship of the disease versus the target network of the drug to see how well the coverage is and what's the literature evidence on supporting them without coming up with any potential pairwise interaction, adverse events. Therefore, like different people with different comorbidity may have different preferences in terms of drug combination. Next slide. So I have been also working on a telemedicine project. This is recent work. We are working with the stroke department. The idea is if we can use a camera to monitor patient at home or in hospital without being intrusive. So we get rid of the background. As you can see, this is a video actually, so I couldn't play it here. But with extraction, we can get a skeletal graph and monitor the motion. So this video shows that people walk and then fall. So before the falling, we detect the falling. This is a confusion matrix on a number of events. We're using this for rehabilitation training. Patients who are practicing at hospital, we record which is the good gesture, what is the bad gesture, and then we learn that. So later we can deposit those camera at home to train them as a biofeedback to tell them to do the right things, because they only stay in hospital for 2 weeks, but over the long time, it's depending on them and their caregivers to teach them what is the correct practice. Beyond that, we also applied homomorphic encryption to protect every frame. So not only the background is removed, the face skeletal is removed, even these points we extracted are encrypted to be sent to the cloud. So nobody will be able to see or infer from the trajectory as well. So this is a paper under review at CVPR. So I think this kind of telemedicine probably will have a lot of usefulness in the future, especially on monitor patient behavior and give them training feedback as biofeedback system. So that's the 4 slides I have. I welcome collaborations.
Thank you, Cheshwan. So if you have a question, just jump in. Okay, then. Oh, yeah, Fabrizia, I think you're muted somehow.
Yeah, muted.
Here I am. Yes, sorry. Yes, I would like to ask a question. As you know, falls are a major issue, not only in the inpatient setting, but mainly in the outpatient setting. So many patients fall at home with devastating consequences.
Right.
So the question is, how feasible it is to set a patient up in a way that he or she will be monitored in every room. Mainly, one of the places where they fall the most is the bathroom.
I know.
Shower, bathtub, and would that be also a cost to the patient? So the feasibility of implementation at home and also the potential costs that the patients can incur.
Right. So there are 2 components, right? One is acceptability. The other is adaptability. The acceptability issue is prominent because there's an early survey showing like 14 out of 17 people do not want a camera to monitor them in real time and send those video sequence to a cloud service. That's why we come up with this privacy preserving strategy to alleviate these conditions. Therefore, we don't directly send the image, the video, we send a skeletal graph while with encryption. This actually can alleviate a lot. We only use very cheap webcam, like $30 webcam. If you deposit on the 4 corners, then you won't have like obscuration, so you can see the patient. Still, like the perception of having a camera in the bathroom will be a very, very hard problem. So even though I'm telling you like there's nothing to be recorded that identifiable, people may not feel comfortable. So I'm working with a faculty at Rice, Hvac. So he actually come up with a new technology with senseless camera. So that the camera doesn't have a lens. So essentially it's all sensor. And all these sensors, Ashok has developed this particular module that can allow you to reconstruct the motion without revealing what is being recorded. So it's look like a cloud. It's just a white cloud. You don't see anything. But from this cloud, you use deep learning algorithm. You can train whether it's like brushing or taking a bath. So I think that would be potentially a way to go. Yeah.
Thank you.
Thank you.
Thank you very much, Shashuan. So let's move to my next friend and colleague, Shaming.
Hi, everyone. I'm Jim Payne. I'm an associate professor in the Department of Industrial Engineering from University of Houston. And here is my, email and also my website. My research interest is mainly in optimization modeling theory, sometimes do some analysis to publish a paper, and also do algorithm design and analysis. And I also work in big data and some machine learning models. And right now is working on demand forecasting or some other forecasting like the spread of COVID-19 and also operation of scheduling. Okay, I also worked on computer vision and image analysis. That's because I worked in computer science before and then later on joined the industrial engineering. Okay, the resource we have here, I think I have a research lab in my department. We have just one server and multiple workstations. And then, of course, we get at UH, we have also this Data Science Institute, and I'm one of the core members in that Data Science Institute, so we can access the facility and all kinds of software there. And we have been actually, as my group has been mainly focused on the optimization modeling and development, particularly for big data analysis and also machine learning problems. I have been working with colleagues from medical center, particularly here the mobile health clinics. Actually, at Texas Children's Hospital, and with the program director actually, and I always call her just a Mitra. Okay, she's from Baylor. Okay, she worked also in Baylor, and some other colleagues at the Texas Medical Center, mainly I think it's for public health. Okay. Also, can you move to the next slides? Okay, so what I can contribute here, to the cluster here is help to develop some of these, quantitative models, mainly based on optimization and machine learning techniques here, and then to develop some technique here for the new models. And particularly in the past few years, actually, we developed some new model to integrate the data from different sources, particularly when you work on some issues related to public health. I just sent some revised slides, okay, to hopefully you got my email, and then otherwise share my my slides here. We have integrated, for example, the sensor track data collected by the American Community Survey data, and then we have also the data from schools, and then we have also the mobile clinic programs. We worked with the program in Texas Children's Hospital, but also MD Anderson and UTMB for cancer screening. So when we had that one, that it's not that easy to integrate this kind of data, but luckily we actually succeeded to develop some new forecasting model to predict the demand for vaccination demand in schools and also in communities related to HSD. And then also based on this analysis, then we made a recommendation to HSD, also the collaborative program in Texas and Children's Hospital and also MD Anderson. So that actually helped to the mobile health clinic program in children's hospital to improve that somehow the number of patients visited per year about 40%, but also reduce the vaccination demand in HISD pretty much almost the same amount. In 3 years, it's year after year. Yeah. So type of expertise I'm looking for is really physicians who use somehow who need help in terms of optimization of machine learning techniques to improve the diagnosis or whatever. Program managers here who are interested in improving overall the operations here or the manager of their program. And of course, I'm also interested to work with any experts whose research really related to an optimization and machine learning and data analysis. Okay. Now before that, my research is mainly supported by like Air Force and NSF, mainly focused on really modeling and methodology perspective. But I know I'm more interested after moving to Houston, because I moved to Houston like also I become more and more interested in healthcare application. That's why right now I'm looking for the programs in NIH and the CDC and some other federal agencies.
Thank you very much, Dr. Peng. Let's see if there is anyone in the audience that has a question today. But of course,
if you allow me to share my slide here, I do have one more slide.
Oh, please, of course.
Okay, let me here. Let's see whether I can share my screen here. Okay. So here is just some sample project here. I already mentioned here. The very first one is improving healthcare access to underserved populations. Okay, that's a project we worked with, colleagues from Texas Children's Hospital and also HISD and Texas Medical Center. But I know my group is also working the forecasting the spread of COVID-19. Basically, we actually come out a new model. The things we know we have, and I know possibly, I would say more than hundreds of forecasting models, but it's we all know that these models actually is kind of hard to achieve good accuracy. Okay, it's mainly due to the large variety in mitigation policies adopted by the federal government and also local government. There are also some unpredictable social events such as massive, gathering, and also somehow it's not easy to identify the key social and economic factors related to the spread of COVID-19. Okay, so somehow, and then we come out the model here, the forecasting model really focus on the spread within the metropolitan area in United States. This is because all these cities and counties in each metropolitan area, they are somehow closely related to each other. And therefore, they almost use the same, mitigation policy. Somehow that allows us to see essentially these patterns, particularly in this large MSS, very easily. And we also incorporate using multi-period here to incorporate here the effect from social events. And particularly, what I would like to mention that is really the so-called trauma service system in Texas. It's designed pretty much like the MSA in the same system. So and this allows us actually to identify the key social economic factors, but also here the overall the healthcare service in Texas, with the spread of the COVID-19. Yeah. That's what I would like to say. Yeah.
I'm kind of confused by what the trauma service system has to do with it. Do you mean trauma as an emergency room, or?
Oh yes, in Texas here, the emergency service is designed in terms of it's not the same name as the metropolitan area, but we did some comparison that largely it's almost identical. Yes, it's essentially here it's area central central unknown, some reasonably bigger city, okay, then you have several counties around this. Like we have the a trauma service area in Houston. Myself, I live in Galveston, but Galveston is another TSA, which is leading, the hospital system is leading by UTMB. Okay, why the Houston is leading by some other health, hospital system. Yeah. So that's why you do have all this information about the hospital systems in each trauma service area. Yeah, if you look at the city and the county level, then it's a bit, there are too much overlap, It's just somehow, I would say it's possibly not so many people paid attention to this. We were just, because I have been doing this kind of analysis using the data from multiple sources, and then we find it's relatively easy if we use focus on the spread of the virus in metropolitan areas. Like right now, we identify, for example, the biggest one is NYC, okay, MSA. In that area, they have more than 50,000, the death toll is over 50,000. That's really the most severe area. And the second one is coming from Los Angeles. Okay, and so we actually know that and then you can see here what's wrong in terms of decision making, or or some of this mitigation.
Thank you, Dr. Penk. I apologize, but we need to move to the third and final, to the third session. So I pass the virtual microphone to Devika.
Oh, thank you, Yanni. And I will not take any more time other than to say it's a delight to have Dr. Zimmelzak here, a collaborator. So I want him to get his full slot of time. So Andy, take it away.
Hi, thank you. So my name is Andy Zimmelzak, and I'm working as an assistant professor at Baylor, and I work as a hospitalist at the Houston VA. Most of my time is research oriented, doing clinical research informatics. That's my term for it, and the term of some other professional societies. But if anyone's not heard the term before, the idea is leveraging existing data sources to help research go, basically. And that can mean research that's entirely self-contained in a database, or that can mean something I used to do more of in the past, which was using the electronic medical record to screen for people who might be candidates for a given clinical trial. So, so there you want to know things like does the person truly have diabetes or not, which there are a bunch of different ways to maybe craft your database definition of a case of diabetes. And I'm not necessarily asking any hypothesis. I'm just trying to retrieve a good number of people with diabetes reasonably accurately, and then feed those into whoever's running the clinical trial. Sometimes that might be the main inclusion criterion for the trial. Sometimes I might be excluding people, making a phenotype for exclusion criteria for a certain drug trial. If they want people who do not have heart failure, I might be tasked with screening those people out for a certain drug trial. And here in Houston, where I've been for probably about 2.5 years now, I've been using the EHR also to research more in the health services realm. So diagnostic error screening and detection. In other words, finding constellations of EHR elements that either look suspicious a priori for diagnostic error, or learning such patterns. In one project that my group at Baylor is doing in collaboration with Dr. Subramanian, in fact, from Rice. So I'll talk a little bit about those resources down there. The VA corporate data warehouse is something I've worked with for several years, I guess since about 2014 or so. 20 million unique individuals and billions of observations of vital signs and medication dispenses and lab results and so forth. It made up of 130 different VA hospitals, not all of whom use the exact same terminology for the exact same or similar clinical concepts, which is where the idea of phenotyping comes in, and really comes in for smaller databases too that are maybe made up of just 1 or 2 clinical sites rather than hundreds of hospitals across the country in an integrated system. One thing that I doesn't really come across if you PubMed search me, but I know a lot about how to actually get things done in the VA and what's allowed and not allowed. That's not a thing you sort of write a paper about, but kind of goes with the territory of VA research. We can probably do the next slide. So I think we talked a little bit about what I can contribute. What I'm seeking overlaps a lot with that. And I think the thing I want to highlight the most goes by a lot of names, but probably one of the more common terms people are using is reproducible research. That means a lot of things to a lot of people, but to me, it means almost every research project that I'm working on has some code that gets generated. And I find it really sad that a lot of times that code ends up on somebody's personal hard drive or networked hard drive, kind of never to be seen again, despite all the hours of work that went into getting it right for a certain research project. I think there's a business case to be made for sharing that sort of thing within your own organization, which I haven't observed happening a lot, no matter where I work. I'm guessing that resonates with some people, that a lot of reinventing the wheel happens, but also for scientific reasons, that if that's lost forever, no one's ever going to be able to vet the results of a paper you published some time ago. I see this improving a fair amount. I see a lot of papers that have links to some publicly available repository with the code, and better yet, the data. Data has some regulatory issues about it, but I think that's one of the biggest things I'm seeking. I'm looking to publish more in this realm of how do you make the research code, how do you get more value out of that, out of all the effort that went into writing what you wrote. I used up about 6 minutes here, and we don't have much time left. I have a couple of slides, if you go to the next, about previous work of mine. This was on the left panel, a simple NLP classifier of very short clinical text reports for that detect a certain type of blood, bone marrow related cancer. And heat map you're seeing is what happens when you train on one hospital and then test on another hospital, and found a kind of an interesting and honestly asymmetrical pattern that is kind of suggesting to me that some sites probably use really diverse language, and those classifiers generalize well, and some others maybe use a more restricted vocabulary. And I think interesting applications for when does a model generalize and not. We've also applied machine learning to some of that lab data integration that we thought that I discussed. When you have 130 different VAs and they're calling things slightly different things and maybe not always using standardized terminology, we developed a way to kind of extend the reach of the clinical expert, where expert might say, okay, these 10 things are sodium, and the machine can say, okay, well, these 100 further things also look like a serum sodium level. Do you agree? Yes, no, you know, check, include them all, or go piece by piece, but hopefully to save a fair amount of time. And then the final slide here. This is a datathon project that we did on Baylor St. Luke's inpatient data, trying to predict several sorts of COVID outcomes. You're looking at length of stay on the left-hand panel and mortality on the right-hand panel, and early stage work, but something that we were able to get going pretty rapidly on, partly because of partly I think because of some of the techniques of having a maybe reproducible adjacent pipeline that can kind of run and re-render everything in one click or nearly one click. I think that's all I have. Little 2 minutes over time, but if anybody wants to ask questions, I guess we can take them live, or feel free to shoot me an email down at the bottom of your slide there if any of this sounds like something you want to get in touch about. So thank you.
Thank you, Andy. Any questions for Andy? Actually, the last 2 slides are very interesting. I will be following up over email because I know people have to go.
Yeah.
Really, really fascinating stuff.
Yeah, Andrew, I will send you an email about the clinical trial. I'm very interested in that. I have ongoing work on that too.
Great, sounds good. Yeah.
Definitely, Andrew, I will talk to you. I did send an email about this, COVID-19, because we are right now. My group is more try to identify the social some of the factors associated with the spread of the virus. And yeah, we have sort of organize the data in a different way using the MSA or the TSA in Texas to somehow the pattern there somehow is cleaner than the classical way, say the most existing way, but definitely got to look at here what's the model you are using and to see whether we can put something together. Yeah.
Great.
A quick question about.
Go ahead, Anna.
Yeah. No, we're over time. I'll follow up with Andy separately on the NLP.
Yeah, and if you don't have Andy's email, feel free to email Dawn, and she will send you her the email of Andy. Although, if you do a Google search, you can find his email very easily.
Yeah, my last name is strange enough that I'm not that hard to find.
All right. So thank you again. Please continue the conversations over email or Zoom or other calls. And Happy New Year to all. Okay. Bye, everyone.
Thank you.
Thank you.
Yeah, thank you. Thank you to all the speakers.
Thank you to all the speakers. Thank you, Devika. Appreciate it.
Thank you.
And all attendees for that.